I haven't presented for months, probably. I've been a bit busy at work, but I'll hope to be back as much as I can. And I bring you an exciting case that I saw very recently on wards that excited me a lot. So I hope it excites you too.
Oh, you're the best. All right, let's rock and roll.
Okay, so let's go on a journey that is going to start at the same place where we started with my first case on VMR that I presented in a very scared way. So the chief complaint is the same. So it's diarrhea and weight loss. And I will pause here.
Wow, I'm already so intrigued that Katerina is presenting a case, and now I'm even more intrigued with diarrhea and weight loss, because Katerina's cases are always so awesome, and I remember her cases from last VMR. So thank you so much for presenting today. So we have diarrhea and weight loss. With diarrhea, it's always important, as with every disease, to establish a time course. Is it acute? Is it subacute to chronic? Acute is usually less than 2 hours, less than 2 weeks. Subacute is 2 to 4 weeks, and chronic is more than 4 weeks. And depending on that, you have different differentials. The thing that maybe pushes me more towards a subacute to chronic process is the weight loss. It's always important to quantify how much in what amount of time. And another thing that's important to ask for red flags. Is there blood in the stool? Are there tenesms? Are there B symptoms? Is there recent travel history? So stuff like that. Robbie, what would you add to that?
I got a little distracted because I see my dear friend Vale is joining us. I haven't seen her in a long, long time. It's so good to see you, Vale. Thank you for hanging out. And then I don't know, there's no neuro dimension to this for Vale, but there seems to be an ID one with the diarrhea. And I think that's honestly the focus is when you hear diarrhea and weight loss, I think you really have to be careful, because both those concerns are subject to inaccuracy, meaning that diarrhea may be constipation with overflow, and weight loss may be not yet verified. So for me, I'm proceeding very cautiously to make sure that we don't end up solving the wrong problem. But if any one of these is accurate, it's much more likely for the weight loss to be a more productive exercise than is the diarrhea. But if you ask yourself, are there a lot of autoimmune diseases that cause diarrhea and weight loss? And the answer is no, not many. One dominant one, inflammatory bowel disease. Are there a lot of cancers that cause diarrhea and weight loss? Not so much. And so if these are verified, the real question will be up Vale's hopefully future career in the world of infectious disease. And it will likely have to analyze the chronicity of this infectious disease. And so for me, all I really want to know right now is this patient immunosuppressed or not? That's the first key question with HIV or other ones. I think that's where I'm at, and would love to learn more from Katerina.
Incredible. So a little more information for you. So this is a 60-year-old man with quite innocent past medical history that I'm going to share with you later. And he basically told me a story that had started 6 months before he'd been admitted, that he'd been having episodes of diarrhea. So this wasn't every day, but quite frequent episodes of diarrhea, and that had been becoming more frequent with time, that he described as greasy diarrhea. It got worse when he ate more greasier foods, but didn't get better or worse with the rest of his diet. So there was no difference with that. He had also been experiencing a lot of aphthous ulcers in his mouth and very intense anorexia, asthenia, and his weight loss. So he'd lost almost 20 kilograms in the 6 months that he'd been becoming symptomatic with time. There was no blood in the stool, no mucus in the stool, so just these greasy stools that he'd been telling me he'd been having. Yeah, I will pause here.
Wow, the plot thickens. So intriguing. Thank you so much. So we now have a time course. It's going on since 6 months. If we assume that it really is diarrhea, so that pushes us into the chronic category of diarrhea, and there we can distinguish inflammatory versus non-inflammatory causes. So I would also ask for fevers, rigors, night sweats, stuff like that. Did you ever get a temperature? That would be important to ask. And also, as Ravi said, the immune status, because that would broaden the differential. Katerina, can you maybe elaborate on that? Did you have any signs of inflammation that you could appreciate in the history?
His review of systems was completely normal. Otherwise, from this, no fevers, no arthralgias, no night sweats, nothing else, just these complaints.
Thank you so much. That doesn't exclude inflammatory causes, but makes them less likely. So you can also think about non-inflammatory causes of diarrhea, for example, celiac disease, which can really also happen in a 70-year-old male, but would be more atypical. IBDs have a bimodal distribution and can also happen in older elderly people, especially the oral ulcers can also fit with Crohn's disease, for example. Another thing that could tie both of them is HIV with oral ulcers and chronic diarrhea, either through itself or through an opportunistic infection. And rarely celiac disease also causes oral ulcerations. Yeah, and for talking about the greasy stools, I would pass the mic to Ravi.
Oh, you got it. Of course, I'm happy to handle the greasy stools. And the truth is they're very slippery. And that's probably because they're malabsorptive. But the problem is that that the translation of greasy stools as reported by the patient may not map onto what we know and understand about greasy stools. In fact, diagnosing steatorrhea, which we're ultimately after, is even vulnerable to being inaccurate with you doing fat analysis in the lab. So at the end of the day, as the chat is saying, you have to take greasy diarrhea and say it's suggestive of malabsorptive disease, but the characteristics by the patient on exam and even in the lab are imperfect. And so you have to tread carefully. The truth is, when you're diagnosing malabsorptive diarrhea, when you're diagnosing it, you're localizing. And let me explain how you're localizing. When somebody has a GI bleed, we've all have been or will be trained to localize it into upper GI bleed and lower GI bleed. In somebody who is having chronic diarrhea, you should try to do the same. Is somebody having an upper GI cause of diarrhea or a lower GI cause of diarrhea? And let me share a fun fact with you. Malabsorption, upper GI tract. Secretory, lower GI tract. Why? The small bowel absorbs and the colon secretes. That's simple. Write that down. I don't know why that's not taught. It's fundamental. So this patient with greasy diarrhea is telling you that they probably have an upper GI process, unless the GI tract is in fact perfect and they are ingesting something that cannot be absorbed, like non-decomposable sugar and laxatives. So Sammy, I think, what does the greasy diarrhea say? Just like everything we've gotten so far, until we see the patient with our eyes and see that he's lost weight, until we see the diarrhea, you have to be very careful not to be misled. So nothing is made of concrete. It's all sand right now. But if it's greasy is in fact malabsorptive, there's a problem in the upper GI tract, and that's all you can say really. So hopefully Katerina can tell us more.
Yeah. So as I told you, he has his past medical history is nothing special. He had hypertension in the past, but wasn't medicated anymore. He also had GERD, and he'd had gastritis with H. pylori positive that he had eradicated in 2016. Also anxiety, but he wasn't on any medication at the moment. His family history was completely unremarkable. When it comes to his social history, he's actually not Portuguese. He came to Portugal from Guatemala at the beginning of the year. So he'd been here for almost a year, since January. And in Guatemala, he lived in the city of Guatemala in an urban area. He was a project manager, had no contact with pets or other animals. His diet was normal. He didn't eat fish or vegetables. Otherwise, he had no other restrictions. Yeah, so that was it when it comes to his social history and his health-related behaviors. He didn't smoke, drinks only socially occasionally, and he had no allergies. So going into his vitals, so his temperature was 36.5 Celsius. His heart rate was 81. His BP was 120/70. And his respiratory rate was 15. And he was setting at 100% on room air. He looked tired. That is the best way I can describe it to you. He looked thin and tired and pale, but otherwise well appearing. And his physical exam was only positive for a few sores in his mouth, but were quite small, 3 or 4 of them, about 5 millimeters of diameter, that were painful. And the rest of his exam was completely unremarkable, including his abdominal exam. So his abdomen was soft and tender, no organomegaly, no masses. Yeah, and I will pause here before going into labs.
All right, a lot of interesting information and a lot of pertinent negatives. That's also finding not only positive findings help us, but also negative findings. So the past medical history isn't like too intriguing to me. Katerina did a very good job asking about exposures and ID related informations. What did the patient eat? Is there any risk for any exposure? So the family history is also interesting, that it's unremarkable. For example, IBDs have a strong family predilection. So if that's positive, that could be a clue. Otherwise, it's interesting that there's no other signs of autoimmune disease, which maybe makes celiac disease less likely. If that's basically all I can make out of this information. For the physical exam, it's also not really too revealing. The vitals are basically unremarkable, except for the maybe a little bit paleness and the sores in the mouth. So maybe the patient could have anemia, which would most likely be anemia, iron deficiency anemia, if it's also a malabsorptive process, or it's anemia of chronic disease, which the labs will show. And maybe the sores in the mouth, I don't really know what to make out of those. Could be unspecific, but could be a clue. The fact that they are painful, and maybe think about herpes simplex, for example, or I don't really know if other ulcers tend to be painful. I know that, for example, in IBDs or Crohn's or HIV or Behçet's, you can also have sores, but I don't know if that would tie that together. I don't know, Robbie, how do you approach mouth sores, and do you have a schema for that on approach?
Sammy, your approach is absolutely superb. I see, oh, hold on, I want to admit, I see Nalayan just joined us. Hello, Nalayan. Yeah, your schema is superb, honestly. The honest truth is, yes, we have a schema for aphthous ulcers that's actually, your timing is incredible. We're uploading it to RLR CP solvers on Sunday, hopefully. Let me take a little detour, because some of you may not know that, because we plug it so hard on Twitter. I was actually just pulling up the chronic diarrhea schema on the where is it? On the RLR CP solvers website. Oh, I don't have it here. One second. I want to show you guys real quick, and hopefully we'll have the aphthous ulcer schema there too. But I'll take over the screen real quick, Shema. So for those of you who are interested, you should know, as a big disclaimer, that can you guys see? I don't know what you see. What are you guys seeing? Oh my God, this is so complicated. Do you see the chronic diarrhea? Perfect. So just so you guys know, we started a new website. It's rlrcpsolvers.com. And the whole point of rlrcpsolvers.com is for those of you who are able. It's about $180 a year, and it's really injects fuel into supporting all that the CP Solvers does. That's the primary purpose. why would you do it beyond that if that's not a primary interest of yours? It has schemas on steroids. And so we upload all these schemas. And so I was actually cheating and reviewing the chronic diarrhea schema, which was very, very helpful for this case. But yeah, check it out. And if you're already subscribed, which I know a lot of people here are, we're hoping to upload an aphthous ulcer schema and a video later this week. Sammy, the truth is that the only nuance to the approach to aphthous ulcers is the same kind of nuance that we approach patients with zoster, which is it signal or is it just a vulnerability of this patient to get recurrent oral aphthous ulcers? And the most common scenario is somebody has a predilection for recurrent aphthous ulcerations and gets them in the context of a systemic trigger. And at the risk of personal disclosure, I have recurrent oral aphthous ulcers. And when I was on my ICU rotation as a resident, it was the absolute worst, like really horrible ulcers, can't eat, can't drink. It was miserable. And now that I get to hang out with you all so often, they happen much less frequently, but they still happen. So I'm also a little bit worried that, again, this case is just so full. Umaima seems to have, and I don't want to disclose anybody's information publicly. So yeah, some other people in the chat also have them. So I think the question in this case, again, is it signal or is it noise? And I'm sorry to keep bringing that up, but there's no anchor yet. We're still like very, very careful. And I think that the only additional diagnoses that enter the fray when we hear that this patient is in Guatemala is a list of potential infectious diseases, the most notorious of which to affect people from this region is tropical sprue. Sammy, have you heard of tropical sprue? Has it crossed your radar?
Yes,
Yeah, tell us more about it.
It's mostly in people who reside in tropical or subtropical areas who stay there for a certain amount of time that are presumably exposed to a certain bacteria or toxin that's not really known, and they get this celiac-like disease, but usually can have similar histology on duodenal biopsies, but have negative serologies, and they usually respond to a trial of doxycycline, I think. So it could be a reasonable idea here. I don't know about the oral ulcers.
100%. I couldn't agree more with you. All right, Katarina, tell us more, please.
Okay, going straight into labs. So his white blood cell count was 6.8. His hemoglobin was 8.9 with an MCV of 112. And his platelets were 142,000. His ESR was 45, and his CRP was 1. His creatinine and BUN were normal, so was his liver panel. His LDH was 500. His albumin was 4.5. And his total protein was 7.3. TSH was normal, and his sodium was 140, potassium 3.9, calcium was also normal, so was his phosphorus and magnesium. And I will already share with you his iron panel was completely normal ferritin and everything, 480 of ferritin, normal saturation, and his folic acid was 3.9, so on the lower limits of normal for our lab, but his B12 vitamin was completely below the threshold of detection. Okay, and I think we can stop here.
Da, da, da. I just want to jump in to be like, you watch, if you have a case to present, please present it. Why? Because if you do as many as Katarina has done, you become an expert at this teaching. She's teaching us by telling us, choosing what data to put where, that a lot of knowledge goes into that. So please try as you join more and more of these to watch what happens to people as they do the skill. Katarina does absolutely amazing storytelling and case presentation, and I'm excited for Sammy to dissect it.
Wow, that was a bunch of interesting information, that I really don't know yet how to totally tie together. But the pertinent positives are we have an anemia that's macrocytic, or that's the MCV is too high, and you can differentiate between megaloblastic and non-megaloblastic anemias, macrocytic anemias. Here we have a reason why the platelets could be too big. We have vitamin B12 deficiency, which usually causes a megaloblastic anemia. We also have low platelets. And just a plug I wanted to make that I learned from RLR very early on: whenever you see low erythrocytes or low platelets, always think about TMAs, thrombotic microangiopathies. The MCV could also fit with those if you have a hemolytic process and get reticulocytes into your peripheral blood. The LDH could also fit with that. But here we have a better explanation with the B12 deficiency, which can also cause a TMA, but it's very rare. So yeah, basically what we are approaching here, I don't know if the B12 explains the CBC abnormalities, but it could. Otherwise, the LDH is elevated, which would also be compatible with the LDH, with the B12 deficiency. And now we have to ask, why is this patient B12 deficient? There you can very easily think about decreased oral intake. For example, if someone doesn't eat meat, or you have causes of malabsorption, or for example, pernicious anemia when you have autoimmune gastritis, or you have, for example, a disease affecting the terminal ileum where B12 absorption occurs. And if, for example, if you have Crohn's disease affecting a terminal ileum, you can get B12 malabsorption. That could also cause that. And yeah, now I'm a little bit stumped approaching all of that. It still fits with malabsorption. I know that you can get a stool osmolar gap. I don't know how often that is done to differentiate between secretory and osmotic processes. Another important thing that you can ask is the diarrhea occurring at night, which would fit more with the secretory process. And yeah, for more clarity, I would hand the mic to Ravi.
No, I think you're absolutely right, my friend. I think your mind made such wise connections to see a low B12 and say that can cause a macrocytic anemia and a thrombocytopenia. And then you taught us it can also cause the elevated LDH, which on the surface seems counterintuitive, because the whole point of B12 deficiency causing cytopenias is that you are unable to make enough cells, and so you have less cells to be there. So can you teach us how you make the link between an LDH and the CBC abnormality? So how can B12 do that?
From what I remember, if you have B12, that is important for, like, I don't know how it's called, for DNA synthesis. And if you can produce proper RBCs, they will get hemolyzed in the bone marrow, and that's how you can get like signs of hemolysis with B12 deficiency. And LDH is like one of the most sensitive markers.
Excellent. So when you see a high LDH with a high MCV, there's only two possibilities. One, well, three, to be honest, but the third one is an exception. I'll tell you why. One is you have a hemolytic anemia, and the high LDH from hemolytic anemia is from the red blood cells breaking down, and the high MCV is from reticulocytes. Why is that less likely here? Most hemolytic anemia is much more acute than a 6-month course. So hemolysis is possible, but less likely. What's the other common scenario? It's called ineffective erythropoiesis, where the hemolysis occurs in the bone marrow as a result of dysplastic cells. What are the two most common causes of dysplastic cells? B12 deficiency and myelodysplasia, MDS. This feature here is consistent with both MDS and B12 deficiency, but the B12 deficiency is low, which prioritizes that possibility. What's the third scenario of high MCV plus high LDH? It's cirrhosis. Patients with cirrhosis have liver source of LDH, and they have a high MCV because of alcohol or because of the cirrhosis itself, the liver disease itself. So when you see macrocytosis and an elevated LDH, it's either cirrhosis, overt hemolysis with a reticulocytosis, which is more acute, or ineffective erythropoiesis. So the B12 here explains everything. And Sammy, as you so aptly said, you started to say this case now distills down to B12 deficiency. And you started to share a schema for B12 deficiency. Folks, this is the key point in this case to try to make diagnostic progress. All right, I see some heads looking up now. This is the key moment. This patient doesn't have B12 deficiency. This patient has extreme, isolated, disproportional B12 deficiency. And it's that feature of this case that is very illustrative and informative. And the two causes that I know of that do this are selective B12 dietary elimination or tropical sprue. We don't understand why tropical sprue has such a disproportionate effect on B12 and folate. But you can see that our friends from India and Pakistan, Danya and Nikita, are jumping on the tropical sprue hypothesis because it's most described in South Asia. And this is such a powerful feature. In fact, it's so powerful that a diagnostic clue can be a sustained, an abrupt, lasting response to just B12 and folate supplementation, followed by diagnostic clarity with EGD and biopsy, followed by treatment with doxycycline. So in this case, Sammy's schema for B12 deficiency is superb. A small side schema that you can say extreme, isolated, disproportional folate and B12 is a clue to dietary restriction of these elements or tropical sprue. Let's address one question off the bat. Sammy, we said tropical sprue is a problem of tropical regions, but this person has been gone from Guatemala for over a year. How do you reconcile that with the tropical sprue hypothesis now? Do you know?
That's such a good point. I have really no idea.
I'm so glad we finally found something that Sammy doesn't know. And look how long it took, 34 minutes. It's fascinating. Patients with tropical sprue continue to manifest the disease well outside those regions when they travel. However, people who travel to regions with tropical sprue do not get this disease unless they've been there for a prolonged period of time. So we think it's some sort of chronic infection that lasts even when people leave these regions. But if you travel to a region endemic for tropical sprue, short-term travel does not result in the disease. It's really interesting. Now, Sammy, you can feel free to come back to San Francisco and yell at me if we're completely wrong, and we might be, but it's hard not to ignore this crew. Katerina, please take it away.
Okay, so let's fast forward a little bit. So this was very obviously malabsorption. So we wanted to know what other things he wasn't absorbing. And so it turns out he also had a deficit of vitamin D, vitamin E, and vitamin K, which we supplemented, of course. His workup for celiac was negative, his HIV serology was negative, and a very extensive microbiology workup in the stool was negative for bacteria or parasites. Okay, and so we went and did the EGD and the colonoscopy, which showed no morphologic changes other than a granite appearance in the duodenum. And we also did a PCR of Whipple's, which was negative in the duodenum. And at this point, we discharged him home because he was doing better on his vitamin supplementations. And I told him to meet me in the clinic for us to see his biopsy results later. So yeah, I will leave you in the suspense like I was for 3 weeks, and I will tell you the final diagnosis.
Oh, what a case. I'm completely humbled. Yeah, so we have more signs of malabsorption, and macroscopically the duodenum appears, or the small intestine appears normal. Another thing that came to mind is small intestinal bacterial overgrowth. That's maybe something, and we could also add, I know that it also causes very high folate and low B12. but it's usually associated with tuberculosis or other structural abnormalities. I don't know if we got an IgA level for celiac disease, maybe it's IgA negative. Otherwise, I don't know how sensitive the PCR for Whipple's disease is, would be the right person that should happen to an old elderly male, but he has no arthralgias nor chronic back pain, but could still fit. Yeah, otherwise, I really don't have much more ideas. Robbie, what do you think?
My dear friend, you're absolutely superb. You literally narrated every diagnosis. I'm going to do a sneak preview. I'm not supposed to do this, but I will because you guys are amazing. Of another schema on RLR CP solvers that Sammy basically just told you. I'm going to show you the visual. Take a look at this really quickly. Seronegative celiac disease. Either this case is seronegative celiac disease for IgA deficiency, or the patient has one of these conditions. Which one of these will have a normal histology? Probably this. So what would I do? I think that it's hard not to invoke tropical sprue as a working diagnosis. And one thing that I learned, because I spent 12 years in Pakistan and have a nice working relationship with a couple of doctors there, is it really depends on your comfort level. You can empirically start this patient on folate B12 to see if they improve. That is a very helpful diagnostic test. You can also even go the extra mile and say the harms of doxycycline therapy are not that bad. Let's try it and see how the patient responds. It won't change your diagnostic calculus. Of course, if this were happening in the United States where the experience with tropical sprue is much less, then I think people would be reluctant to do that because we don't do that very often. So for me, I think that this could be any of those things, honestly, but the law of proportionality, there's no systemic disease, there's no lymph nodes anywhere, there's no drugs involved, there's no evidence of an immunodeficiency, there's no evidence of a colonic involvement to suggest Crohn's or ulcerative colitis, and the patient has a great profile. He's from Guatemala, he has disproportional vitamin D, B12 deficiency. I don't know if it's tropical sprue, but I think I would be inclined to give him those harmless therapies and see how he responds. What do you think, Sammy?
I'm with you all the way, always.
Oh, wow. I'm honored. You're making me blush now. All right, Katarina, enlighten us, please.
So basically, you guys are in my mind. I was thinking the exact same thing, but I decided not to send him home on antibiotics yet. So he was doing better on vitamins. And I was going to see him in 3 weeks. So that's what I did. And I saw him on Tuesday, actually, 2 days ago. And he was doing amazing. And we already had his biopsies back. So his duodenum biopsy showed villous atrophy and a very marked inflammatory infiltrate with lymphocytes and plasmacytes. And his terminal ileum biopsy didn't show any atrophy, but showed even more inflammation with a lot of eosinophils. And this, for me, sealed the deal for tropical sprue. So yeah, you guys nailed it right on the head.
Amazing. I'm so glad you're here, and every single time you humble us. Sammy, what open questions is your mind having right now? What parts of this case are curious to you?
Wow, Katerina, thank you so much for this case. I'm completely stumped. I did not know that you also see findings in tropical sprue in the terminal ileum. I was like more evoking Crohn's disease, although there were no granulomas. I really didn't know that, and I learned so much today. Thank you so much for this amazing case.
God, I was struck by two incredible things. I think, Katerina, every time you present cases here, you bamboozle us, and I will completely reinforce Umaima's plea with you not to disappear again and continue to teach us and humble us. Thank you. And I just texted Katerina on WhatsApp to be like, at some point you're going to have to discuss a case with us in addition to presenting. So we'll have to pile on the discussion pressures. But speaking of discussions, I mean, you all know that Sammy last minute agreed to co-facilitate today because we had an absence, and every single time the way you teach us with your humility and with your knowledge is incredible. To teach us about diarrhea, to teach us about oral ulcers, to teach us about your schema for B12 deficiency with so much humility is amazing. And Sammy, I have the exact same knowledge gap that you do about, I thought it was just a duodenal disease alone, but it makes sense that it involves the length of the small bowel. There's nothing unique about the duodenum. Yeah, so thank you all. And Katerina, what lessons did you take away from this patient, and how is he doing now?
He's doing pretty good. Of course, I saw him on Tuesday, so and he was doing better, gaining weight, no more diarrhea, just on vitamins. But I still started him on doxycycline because he already had some atrophy in the duodenum. Basically, when I heard the story when he came to our ward, this screamed terminal ileum to me at first because steatorrhea and B12 deficiency. So I knew something was wrong in the terminal ileum. But when I started hearing Guatemala and everything, I wanted to know what was going on all the way up to the duodenum. So yeah, it was a really challenging case because we don't have tropical sprue in Portugal. I just found one reported case like 30 years ago, but we're going to have more because we've been having a lot of immigration from South America. So yeah, this was really cool, and it was very different from other malabsorption cases that we've been having. It wasn't a protein losing enteropathy, which was surprising. But yeah, it was pretty cool. And you were right. The abscess ulcers were not, it was just smoke, probably due to the B12 deficiency and the anemia. So this was really fascinating. And we'll see in January when he finishes the doxycycline, I'm going to see him again and I'll have some more things to tell you. Yeah.
Absolutely amazing, Katerina. Amazing. I'm so grateful for you to present and excited for Leah to take us through the journey again.
Yes, so I have the honor to share the teaching points for this case. And I think there were so many pearls in here. I'm just going to highlight a few. But the main complaint here was diarrhea. And we can summarize this with 3 points I found. So it's important to ask about the time course. It is very helpful to think about the mechanism and about the localization. So we did these things by first of all, because acute and chronic is very helpful in differentiating between infectious and other causes. And this patient had steatorrhea, so fatty stools, and that is something that should make us think of malabsorption because fatty stools, it was not, the digestive or the process didn't work. I'm missing the words here, but where could we find that? When fat digestion is not working, when we don't have the biliary secrete, so biliary obstruction would be a cause of pancreatic insufficiency. And something that came up here too and was reflected in the labs is the deficiency of specific vitamins. And so I always think about the DECA mnemonic to think about the vitamins that need that are fatty and part of the digestive process here. So this showed us, okay, this might be a malabsorptive process. And then Robbie taught us about this important thing to consider, is it upper GI or lower GI process? And malabsorption, again, helps us to think about, okay, this might localize to the upper GI with some exceptions. And secretory diarrhea is usually a lower GI because it localizes to the colon. And then looking at the lab with this patient, we found that he had an elevated LDH, which is one of the parameters that makes us think of hemolysis, because it's an enzyme that should be inside of the cell, but when the cells are destroyed and burst, it gets out, so it can be measured. And that's why also the haptoglobin is then low, because the hemoglobin gets out of the cells. So we thought about causes of elevated LDH and elevated MCV. And there are a few scenarios to think of. We have hemolysis or reticulocytes that cause elevation in MCV. We can have ineffective erythropoiesis with B12 deficiency and cirrhosis. And B12 is important for DNA synthesis, as you all know. So that's also why then hemolysis might occur, because there's this disruption of this process. So this case was different because we had isolated B12 deficiency. And there are again two things Rabi taught us, which is selective dietary elimination and tropical sprue. These are two causes that can cause this very special constellation. And because of epidemiology, because of the diarrhea, we thought of tropical sprue, which is a celiac-like disease that you can get if you have long time travel in these endemic areas. And usually serology is negative for celiac disease, as was in this case, but the histology is characteristic and might clue you into this diagnosis. And as was the teaching point for many of us, it's not limited to just the duodenum. Yes, and there was a lot more in this, but yeah, thank you for listening if you're still here. And thank you, Sammy and Rabi, for discussing this case from Katerina.
Oh, we're all still here. How could we leave? We were also learning, in addition to your superb teaching points, that there's a supermarket, and Max was just teaching us that there's a supermarket named ADEK in his part of the world, which is in Austria, which is absolutely amazing. And I love this case. Thank you, Leah, for the incredible summary, and Katerina for the superb case, and Sammy for the discussion and dissection. Hope to see you all tomorrow for RLR at 9 a.m. Pacific. Bye.